can you tell me a little bit about how you got into gynecologic surgery?
Yeah, my mentor was Glenn Hurt, and I remember very distinctly when I was a second year OBGYN resident, there was a postpartum woman who was readmitted with a fistula, and she was 19 years of age and was obviously devastated by realizing the stool was coming out of the vagina. And participating in her patient journey from that initial readmission to several weeks later, fixing this fistula in a very elegant transvaginal, relatively quick surgery that revolutionized or restored her back to her normal self. When I saw her back in clinic about 6 weeks after the operation, and she was there with her baby and, was really just talking all about the repair of her surgery, the fistula, as opposed to the delivery experience, I realized that the impact one could have as a skilled and, sort of topic specific expert was something that I was really drawn to. I'm one that I know I love fixing problems. And so the elegance of fixing this life-threatening, from a quality of life perspective, operation was drew me in very quickly.
Tell me, what do you think makes a good gynecologic surgeon?
That's a question I ask of fellows coming to interview. So I've thought about this. The number one thing is curiosity. You have to be curious about what you're doing, how you're doing it, how you can get better, what's happening with your outcomes. So I think that it has to start with curiosity. Meticulous attention to detail is something that makes everyone a better surgeon, both in terms of learning to discriminate subtleties of surgical fields, subtleties of approach, how things may look a little different before things go wrong. I think that having really careful attention to the detail of the surgical field is a paramount thing. The next thing I think makes a good surgeon is willingness to practice. None of us get great. None of us are naturally born at being great. You have to work at it. And so people that are willing to spend the time to get better, practicing outside the operating room, I think make great surgeons. And then, finally, being willing to put yourself in uncomfortable situations and keep learning. I think that the greatest growth that I've had as a surgeon is in really difficult surgical environments, South Sudan, Uganda, being in places where you really have to be pushed beyond your comfort level to grow and expand. And so being willing to put yourselves in those difficult circumstances can really make you grow and become a great surgeon.
It's a constant, that's why they call it a practice, right? It's a constant evolution. Mark Walters used to tell me, once you're not evolving, you should just stop. when you think you don't have anything more to learn, then you should just stop. So the theme of the upcoming SGS meeting in the spring is surgeons as change agents. What does that resonate with you in any way? What does that mean to you?
I haven't thought about surgeons as being change agents, other than with the story that I started with, is obviously that we were the most profound change agent for that patient in that moment. Patients come to us to restore back their quality of life to where they were initially. And so I presume that we're the greatest change agent for being able to restore health and life to people. And that's one of the things that I find so amazing about being a surgeon, that you can affect that change. I'm eternally frustrated by managing things like bladder pain and recurrent UTIs, because you never fundamentally change those things. But as a surgeon, you walk in with a big prolapse and, a couple hours later, it's changed. And I find that to be eternally gratifying. And so I know that about my personality. I know that I need to be able to affect change, to feel like I'm doing something positive. And so I like that it's framed in that way. And gosh, thinking about the work that we do in Africa, the abject misery that these women are facing when they come in, gosh, the most devastating patient that I remember from our last camp was someone who'd lived with, a 6 centimeter defect between the rectum and the vagina as a consequence of sexual trauma at age 14. And she'd lived for 5 years with the memory of the trauma and with the daily physical, catastrophe of large volume stool coming through the vagina. And fixing that fistula, I think, makes me really think about being a change agent.
Along the same lines, not as the surgeon itself, but changes in gynecology, what do you sort of envision the next evolution of that gynecology, will be or may be? What upcoming changes can you picture?
Cecile, I've always found it fascinating that obstetrics and gynecology are merged into one field. It seems that, it's unfortunate that it's merged into one field because there are such different things. It's almost like, women just need to have one specialty practitioner that can do it all. And, with the change of the technologies by which we're doing surgery, it's become so much more complicated. Now a resident is expected to, within the relative confines of the gynecology portion of their OBGYN residency, learn open surgery, laparoscopic surgery, vaginal surgery, V notes, robotic surgery. And it's really completely overwhelming, which is probably why we're seeing less and less experienced surgeons graduating, because they're really dabbling in all those different modalities as opposed to really having time to get good at any of them. So what I would like to see changed is that they're totally separate residencies. I think that obstetrics is a completely different set of questions and circumstances than gynecology, and they happen to be the same gender that is experiencing these things, and that's pretty much it. And so I would like to see, with the growing complexity of gynecologic surgery, that gynecology becomes a separate specialty.
I'm also interviewing Javier Magrina, so I'm sure I'm going to get a very similar answer from him, since he's written a lot about separating the O from the G, right?
Yeah.
I think that you are amongst many who feel this way, and I think we've been talking a lot about it at SGS. Speaking specifically of SGS, what has SGS meant to you in your career? Has it helped your career? Has it played a role in it at all?
Yeah, my gosh, I have such a distinct recollection of Ray Lee delivering one of the keynote lectures at one of my first SGS meetings. And Mickey Karam had presented a video of a urethral diverticulum in which they'd used a Martius flap. And, I remember Ray Lee's just really beautiful professional critique of the video and the presentation. And from that moment, sort of recognizing the profound surgical excellence that SGS draws and what all of us as surgeons can really learn. And, when we were just attending the AUGS meeting last week, we recognize that the field has grown far beyond surgery, but in large measure, the surgery then is not the focus of the meeting. And to have pelvic surgery be the focus of the whole meeting is something that is really unique and something that I really value. And I think that we all can help each other grow to be better surgeons through organizations like this. So for me as a surgeon, it's provided a forum for ongoing learning, collaboration, networking that has been profoundly impactful.